Hello, everyone, and welcome to the Clinics Review Articles podcast series. I'm Carrie Holland, the managing editor for Infectious Disease Clinics of North America here at Elsevier. Infectious Disease Clinics is a quarterly publication consisting of review articles focused on a central topic related to infectious disease clinicians. Today, we will be discussing the current June 2024 issue dedicated to Urinary Tract Infection Challenges Beyond the Basics, guest edited by Dr. Kalpana Gupta. She is Chief of Infectious Diseases and attending physician at VA Boston Healthcare System and a professor at Boston University School of Medicine. Also joining us today is author Dr. Barbara Troutner, Professor of Medicine, Infectious Diseases and Health Services Research, Baylor College of Medicine, and consulting editor Dr. Helen Boucher, Dean and Professor of Medicine at Tufts University School of Medicine and Chief Academic Officer, Tufts Medicine.
I'm honored to be here with two international experts in the field of urinary tract infection, Dr. Kal Gupta from the VA in Boston and Dr. Barbara Troutner from the VA in Houston. Thank you both for joining us and for helping contribute to what is one of our most popular editions of ID Clinics, focusing on urinary tract infection. In this edition, you covered topics from recurrent urinary tract infection, antimicrobial stewardship, the microbiome and the role of potential diagnostic tests, treatment for uncomplicated and complicated UTI, and then one of our most vexing clinical problems, treatment of UTI in our male patients. So I look forward to the discussion. And maybe Dr. Gupta, I'll start with you. One of the most hot topics recently was the approval for the first time in over 20 years of an antibiotic for uncomplicated UTI. So do you want to just update us on the world of uncomplicated UTI and whether this new drug is a big deal or not a big deal?
Sure. First of all, thank you for having us, and we're excited to talk with you today about UTI. And it is true that really the agents available for treatment of uncomplicated UTI have not changed very much in the past few decades. But there are some new agents on the horizon, and the first one to talk about is the one that just recently was approved by the FDA, pivmecillinam. What's interesting about this antibiotic is it's actually been available in other countries for many years, and in fact is included in our 2011 IDSA guidelines because that was an international guideline that included European countries. The Netherlands in particular used this agent actually as a first-line agent for treatment of uncomplicated UTI. And there's several studies already out there comparing this agent, which is a beta-lactam, with some extended spectrum activity. It's been compared to placebo and ibuprofen and other antimicrobials. And overall, in the studies that were submitted to the FDA based on the website, it's found to have a composite success rate somewhere in the 55 to 66% range, which, by the way, when we look at uncomplicated UTI studies, might sound a little bit low, but the composite success includes microbiological and clinical success. So those rates tend to be relatively low compared to what we see in the clinic, for example, when we treat our patients. It does look like it will be available in the U.S. And I think the questions that will remain until we are more comfortable using it is what is the optimal dosing and what is the optimal duration and how are patients going to do with it? Where will it fall in the newer guidelines, I think is still up for question, and we await those.
Great. Thanks, Dr. Gupta. Dr. Troutner, anything to add?
Just that it's, of course, wonderful to have a new oral agent for UTI. I think it's not going to cover Pseudomonas, to my understanding, which, of course, is not a major issue for UTI. But I'm so often seeking oral agents that do cover Pseudomonas. So perhaps one slight drawback to that drug.
Great, thank you. And Dr. Gupta, you said we need to know the optimal dose and the optimal duration. Tell us more Was there some issue with the study that didn't help us figure that out?
Well, there's many studies using pivmecilin that have used different doses. In fact, there's a study that's a meta-analysis of the different doses and the different durations, because I don't think that it's quite clear whether there's something that's optimal. And when you look at the FDA approval, by the way, was for the 200 milligram dose, and it's ranging from 3 to 7 days of duration. So that tells you something right there, that there's that's a wide range in terms of treatment for every episode of uncomplicated UTI. What we know from previous studies is that 400 milligrams can be used, that it may actually do a little bit better when you have somebody that has a resistant organism. So, for example, in ESBL, which is a place for this new antibiotic to be considered, you may want to use the higher dose. And then the difference between 3 days, 5 days, and 7 days, again, remains a bit unclear. And we can certainly talk about duration of therapy, but it will probably depend on the patient you're treating that's in front of you in terms of how sick they are, their rapidity of response, and whether or not they've had recurrent events. And this is, first time, second time. And then realizing that if you go shorter, sometimes shorter durations do have an increased rate of recurrence, and just talking with your patient about that. But there's obviously benefits to going shorter.
Great. Thank you for that. So maybe now we can pivot a little bit to complicated UTI. And for our listeners who may not be UTI experts, Dr. Troutner, do you want to just remind us the difference between uncomplicated and complicated, and maybe provide a little bit of insights into what's happening in the world of complicated UTI today?
I'd be glad to. And I think my answer, depending on who you ask and how passionate they are about the topic, the discussion could now take 3 hours, or I could get it down to 3 minutes. I think we're very practical, those of us on this call. So we're going to get it down to 3 minutes. It just makes it easier. So if it's uncomplicated, the infection is confined to the bladder. It is cystitis. If it is complicated, then the infection has probably extended beyond the bladder. You either have systemic signs or fever or bacteremia. And we also would lump certain groups in the always complicated category, such as people with indwelling urinary catheters, because by the time they present with symptoms, it is usually an infection extending beyond the bladder.
Great. Dr. Gupta, anything to add?
I think the piece that clinicians have to know is that there's guidelines and randomized trials and FDA approvals, and a lot of those use the older definition. So, we're used to talking about all men, for example, having complicated UTI, or maybe even patients with diabetes, putting them into the complicated UTI bucket. And now, as Dr. Troutner alluded to, there's recognition that in the clinic, when we see our patient, we kind of have to go by how sick they are. So do they have fever? Do they have suspicion for tissue involvement, meaning kidney or prostate? And if so, they move into the complicated group. But now there's a group of patients who may be male, who may have comorbidities. If they're presenting with cystitis symptoms and without systemic symptoms, without fever, we can move them into the uncomplicated bucket. And what that allows us to do is have a different list of potential therapeutics for that patient, and potentially even a different duration of therapy, and perhaps a different expectation in terms of their chance for recurrence. So that's really what's changing, and I'm hoping it will catch up in the guidelines. I think in this ID clinics volume, you'll see that it's catching up even in as people write about UTI, which is great.
We're trying to think about complicated or uncomplicated in terms of how does that drive your antibiotic choice, and how does that drive the location of treatment, inpatient versus outpatient. Mm-hmm. And with uncomplicated, you can feel safer choosing an antibiotic that may not reach very good bloodstream levels.
Great. All right. Well, since we pivoted to treatment, let's pivot to treatment. So, Dr. Troutner, you took on the oral versus parenteral therapy question, and I'm really interested in hearing from both of you as experts about what are you seeing in 2024 in terms of patients who require parenteral therapy, and just tell us what you're seeing out there, right? The last CDC threat list update showed that outpatient resistant infections were increasing with more ESBLs, for example, in the community. Are you seeing that in your practice? Any other pearls for our listeners?
Yes, I think there's a couple of things. First of all, there's been some new studies looking at step-down therapy. So trying to shorten, if somebody does get admitted and get started on IV therapy, can we shorten down, including people who have bacteremia? We have some very nice data now suggesting that certainly, even with bacteremia, when there's a urinary source as thought to be the etiology, that we can step down to oral therapy as soon as people are responding. What you want to do is make sure you have something, as Dr. Trotter alluded to, that has good tissue penetration, because obviously here we're dealing with potentially involvement of the kidney or the prostate. And if in most studies, that means you're trying to step down to either an oral fluoroquinolone, trimethoprim sulfa. By the time you're doing this, obviously you have the organism and the susceptibility. So you're doing this with informed decision making in terms of, and then also what the patient can tolerate. If you're going to step down to an oral beta-lactam, then you really do want something that has good high dosing. Certainly if you're going to try to shorten your duration to 7 days of therapy total. So I think that's one thing that we know about oral therapy, is that we should be stepping down and getting the patient off of parenteral therapy and trying to, obviously move the patient out of the hospital if that's possible. I'm going to stop there and let Dr. Troutner talk as well. Go ahead. In terms of oral outpatient therapy.
Actually, I'd rather address inpatient, if that's okay. I just finished 2 weeks of inpatient IV consults. What I see may not be the same as what everyone else sees, but when they're consulting us, it is ESBL E. coli. It is people who otherwise could be managed and stay in our long-term care facility, except that someone has tested the urine and found a highly resistant organism, and then they transfer them to acute care so that we can treat it. Some of those cases are very debatable if they need treatment in the first place. But then there's the other whole set of consults, and they're bacteremic. And it's almost always an ESBL E. coli. And a lot of those patients have stones somewhere in the urinary tract. They have some level of obstruction, and they're getting rounds and rounds of urinary tract infections, and they get rounds and rounds of antibiotics. And we inevitably see the outcome. They get an ESBL E. coli.
Yeah, that's a great observation. And the chapter in the edition gets into when to think about using even perhaps stronger agents, some of the newer beta-lactam, beta-lactamase inhibitor combinations. And it talks about other pathogens that maybe we see less frequently. Do either of you want to comment on experience with any of the newer agents for these types of infections? And I'm interested in if and how you're able to influence colleagues to intervene on the stones and other causes of obstruction.
The way I would put it is I would have to be provoked to use one of the newer agents. I'm going to have identification of an organism that I really have nothing else to treat because I know what's going to happen with the newer agents. We're going to induce resistance just like we've done to other things. I mean, in some ways, antibiotics are self-defeating. The more you give them, the more we are inducing resistance. So we would be looking at, when we're trying to decide how to treat the patient empirically, we review all their prior cultures. And, going back, there's no set guideline on how far to go back, but anything within 2 years, I would consider fair game. And if we have any prior culture to guide us, then I'm going to choose the empiric antibiotic based on that. If I don't, I would probably think hard about a patient that was coming from a long-term care facility or that I knew had a lot of prior antibiotic exposure. If I don't have risk factors, though, I would start with ceftriaxone.
Great. Dr. Gupta, anything to add?
Yeah, I think the one thing to add is that when clinicians see a multi-drug resistant pathogen on the culture result, the knee jerk is to focus on that and want to cover it. And I think Dr. Troutner said something very important, which the first thing to do is make sure that this person has an infection that requires treatment. And then the second thing to do is look at that culture carefully and see, is it mixed? Do we need to target that multi-drug organism? Or is it there in very small quantities? And that becomes a little bit nuanced because obviously if it's there and you don't cover it and you're treating them for a UTI, then you may end up selecting out for that organism. So I think at that point you may be talking with your infectious disease consultant and trying to figure out what the best approach is. Fortunately, we do have antibiotics that we can use for many of these very resistant organisms. But there, as Dr. Troutner said, I would be very directed. I would keep it short. And then if there is a nidus, that's the case where you want to try to address that nidus, the stone or the catheter, while you have them on active therapy, so that you can try to really give the patient a chance of eradicating that organism.
Yeah, thanks, Dr. Gupta. That is one of the most prickly things, those conversations with the urologists about trying to get them to intervene while we're on, have them covered with the antibiotic and before wasting too much time. Dr. Troutner.
Well, I just had a fantastic conversation with a urologist yesterday, and I didn't start out with, I'm calling because I'd like you to take out the stone. I said, I was wondering if you could help me decide what additional imaging this patient needs. We had a great discussion. We reviewed all the images together, and the conclusion was there was an obstructing stone that needed to be removed. So asking for advice rather than trying to tell the urologist what to do, not surprisingly, led to a better outcome for all.
Excellent. Oh, that's really great. Thank you. And as a recovering fellowship director, these are the pearls that we need to share with our trainees. So, Dr. Gupta, you talked about, the presence of organisms in small numbers, and, it sounded like you were talking about a conventional culture there, but I wondered if you had any opinions on some of the newer diagnostic modalities and their potential utility anywhere in the spectrum from uncomplicated through the most complicated UTI.
Yeah, I think there's a couple of things happening on the landscape for diagnostics. One is certainly, obviously, there's sort of rapid diagnostics at the point of care using a variety of different methods, but mostly identifying the presence of bacteria and trying to find resistance genes so that the clinician has much more data at their fingertips to empirically choose an antibiotic. Those methods, I think, are still pretty much in development. There may be one or two things out there that's actually available, but they tend to be right now difficult to access and also expensive. And so when we talk about rapid diagnostics in UTI, I think that we need to remember that much of outpatient UTI is still probably going to be diagnosed using standard culture methods. There might be cases, for example, in our sicker patients, or in patients who we're trying to, for example, keep in place, so keep at their nursing home instead of transferring them. Having a rapid diagnostic might help us be able to choose an oral antibiotic or not choose an antibiotic at all. So places where it really could make a difference for the patient, I think those are the places that we'll start seeing rapid diagnostics. And I think that they will help us choose the right drug, the route of treatment. So if we're able to use oral, we would do that. And then potentially help us with diagnosis. The issue with diagnosis in UTI, once you start looking at the urine, if you've moved past symptoms, then you're often going to find a positive result. And that's not going to change whether you're using culture or rapid diagnostics. You're going to get that positive result. So you really need to know ahead of time, what is your suspicion for true UTI in this patient based on their clinical presentation, and then use the culture or whatever diagnostic method you're using to further inform you in terms of what's the best approach to management of the patient. And that is definitely Dr. Troutner's area of expertise, but that's where I see diagnostics changing a little bit in UTI, is sort of in the sicker patients and sort of getting more rapid. information about resistance. Now, there is a very nice chapter on the microbiome. And in that chapter, they do talk about how, as it's really much still in development in terms of understanding the microbiome of the bladder. But I think that these studies will help us to understand what is normal flora, and then when is there abnormal flora? Are there signals that will allow us to do a better job diagnosing clinically important UTI that we need to treat? And I think that's still an area of development, but I think this chapter is so important because the concept of the microbiome, whether it's urinary, vaginal, intestinal, and its relationship to pathogenesis and disease is something that is critically important both for appropriate diagnosis, but then also for management and prevention.
Great, thank you. Dr. Troutner, anything to add?
Yes, I heard we're talking about genome sequencing and the urine, and apparently there are several commercially available tests out there that are not FDA approved, but they're in use. The CDC representatives presented a lovely abstract on this at the recent Society for Healthcare Epidemiology of America spring meeting, and more than 100,000 such tests had been submitted for insurance reimbursement in the U.S. last year, and the tests are marketed as you don't even need a clean catch urine. You could actually do it on like a urine swab from a diaper. So that's going to get into a lot of problems for clinicians and stewards because they're going to identify a lot of organisms. They actually give a report that's a little bit misleading. It looks like a urine culture. It says, E. coli detected and, Proteus detected. So you're going to get a lot of organisms reported, and it's completely divorced from the clinical context. And that can only lead to more antibiotic use, which in turn actually harms the individual patient in addition to our concerns about society.
Great, thank you. Well, so since you brought up stewardship, antibiotics are used in great amounts for urinary tract infection, but I've been taught that they're also used in great amounts for not urinary tract infection. So what are your pearls about stewardship and UTI? Dr. Gupta, we'll start with you.
I think the most important point for stewardship in UTI is before you send off that urine test. And it's looking at your patient and saying, even if they're presenting to you with delirium or even with leukocytosis, even with fever, is saying to yourself, what is my suspicion for UTI, and do I want to send this urine? Because right now, the urine is one of the first things that gets sent for any of those syndromes. And again, we know that in many of our patients that urine is going to be positive. And then we make the relationship between the symptom and the positive urine. Many of these patients get better with antibiotics, but they're also getting better with hydration, other aspects of their care, and time. And so we may be making inaccurate diagnosis of UTI in some of these patients. So that's really where I would start in terms of stewardship. And Dr. Troutner, what do you think?
Sure. So there's a paper in this edition written by Larissa Gregorian about outpatient stewardship interventions for UTI that have been trialed. The take-home message from it, really, there's only one randomized control trial we identified that was only focused on urine. But I think if you had to pick something you were going to do to help with outpatient stewardship for UTI, I would give the providers the information they need to make the right choice in the moment of decision making. That is what you would call, in addition to a nudge intervention, because you kind of restrict what order set is going to pop up, it's a boost intervention because you're giving them the knowledge they need to make an informed choice, but it's been distilled and is appropriate. We interviewed providers in outpatient clinics and said, where do you get your info and where do you like to have it? So it's in the computer and they need to have it when they're making the decision. So if your goal of your stewardship program is to decrease use of one antibiotic and increase another one, provide the providers with that information right in when they're prescribing for UTI. This is our favorite drug. This is one is not recommended as much.
Great. Thank you both. So for the last topic, I kind of saved what is the most vexing in my practice, or what has been, which is UTI in male patients. And this is an area where I feel like we have a paucity of data. We all have patients for whom we've cared for months to years in ways in my practice that have been very unsatisfactory for me and the patient, most importantly for the patient. And there was a great chapter in the edition, and I'd just love to hear, what are one or two pearls from each of you on the topic of male UTI. So maybe Dr. Troutner, we'll start with you.
I think that the question in men with UTI is the prostate involved? Is the epididymis involved? Are other structures involved? In other words, is there ever really a simple cystitis in men? And we don't know the answer to that. I suspect it's a spectrum, just like how we're finding in at least women, there's good documentation that asymptomatic bacteria to, symptomatic cystitis is a spectrum. I think in men, the degree of involvement of other organs and structures is a spectrum as well. That said, how much does it matter clinically? I suspect with an afebrile man that doesn't have known prior episodes of prostatitis or significant urinary retention that you could probably get away with 7 days and call it a day. If they're febrile, though, I'm starting to wonder and starting to introduce in my own practice a brief prostate exam to see if there's additional tenderness. Not the jump or the ooh that everyone makes when you do a rectal exam. It's important to teach our trainees about this, but an actual, it's hurting there, because that's going to change my management duration considerably. And I'm thinking, and this is advice, not evidence, but I'm thinking that we need to start incorporating more prostate exams into our management decision making with men with febrile UTI.
Great, Pearl. Thanks. Dr. Gupta.
Yeah, I think male UTI, to use a loaded word, is complicated, even though it can be uncomplicated. For exactly that reason, which is, are you dealing with bladder or are you dealing with bladder plus tissue? And that will change the antibiotic, because if you're dealing with tissue, you do want to use an antibiotic that's going to really penetrate into tissue well. And it will also change the duration, just based on studies that we know that demonstrate that longer courses tend to do better when you're dealing with prostatitis or prostatic involvement. So I do think that the approach to male UTI, especially men with recurrent UTI, which is maybe what you were alluding to in your question, has to involve trying to understand what is involved, and is there something that's a nidus? Because even within the prostate, you can have stones, you can have things that are somewhat occult, and that is going to result in frustration, because it often will result in recurrences and relapses, even though you've used an antibiotic that is active against whatever you're growing. And that's where we really have to partner, I think, with our urological colleagues, and perhaps use imaging, even in this case, cultures at the end of treatment, to understand how well have we eradicated whatever we're treating, and is it coming back? It doesn't mean that if you get a positive result, you treat them again if they're asymptomatic. It's knowledge. It's understanding what's there and what keeps coming back, because that might explain to you whether there is a nidus somewhere. So that's the part that isn't well written about, because it's hard to study and there's not going to be an RCT on that. But that is probably the piece that is going to help clinicians manage their individual patient a little bit better, is getting more data, and again, using imaging, using our consultants, and on an individual basis, deciding if it's the drug. Do you need to use something higher doses, better penetration? Is it the duration? Do you want to try a longer course? And then thirdly, is there some intervention to be done?
Great. Thanks. Dr. Troutner?
You mentioned that not satisfying for the patient or the treating provider. I saw a man last week who has had 69 urine cultures since 2020. So, we're not reaching this man's needs with our current paradigm of test, if bacteria are present, treat, which is what he's been suffering through.
Yeah, amen.
I think my approach with him is really to sit down and try to define for you, sir, what are the symptoms that you really need us to treat? When do you really need treatment? What else can we do? There's Cal's article in this edition on recurrent UTI talks about drinking more water. Is that one option? And then, and those are cases where I also will try methenamine. It gives me something to try with the patient. There's some evidence for it. And if I can reduce the number of courses of antibiotics he's getting per year by 2 courses, I still think we're coming out ahead of where we were.
Yeah, absolutely. Well, thank you both so much for sharing your wisdom. And I love that this conversation really reflected the edition and went from the sort of clinical basics and the importance of still symptom elicitation, including the patient in the decision-making, like Dr. Troutner, your comment about what matters the most to the patient. It turns out we in infectious diseases, we don't incorporate that into our trials enough. So that's really important. And then Dr. Gupta, the physical exam, the making the clinical diagnosis before we order that test, and then thinking about the resources and the precious resources of the antibiotics that we have in the best way possible as good stewards. Really, really appreciate your wisdom and spending the time with us. Thank you so much.
Thank you.
Thanks so much for taking the time to discuss these important topics, Dr. Gupta, Dr. Troutner, and Dr. Boucher. And thank you to our listeners for joining us for this edition of the Clinics Review Articles podcast series. For an exclusive discount on the issue we discussed today, focusing on urinary tract infection challenges beyond the basics, visit us.elsevierhealth.com/expert. Infectious Disease Clinics is available for individual print subscription with accompanying online access, as well as individual online-only access, and is available on the Elsevier electronic platforms Clinical Key and Science Direct. For more information on this series and our nearly 65 other titles spanning all medical and surgical disciplines, visit info.theclinics.com. Be sure to follow us on X, formerly Twitter, at Clinics Reviews and at ID Clinics, and subscribe to the Clinics Review Articles podcast wherever you get your podcasts.